So, let us see the complications of kidney disease. We will look at it from 2 points. One is complications of the central nervous system as well as neurological complications of dialysis and kidney transplant. And I will be only talking on the chronic kidney disease today. Can be affecting the peripheral nervous system or the central nervous system. We will deal with it individually. Now, I will be speaking on the peripheral nervous system manifestations of chronic kidney disease. We all know peripheral neuropathy is a condition where it is usually length dependent, affecting the extremities and usually involving the hands and feet, producing paresthesias, numbness, glove and stocking distribution. This is a classical peripheral neuropathy. Of course, we can have other manifestations like a multifocal mononeuropathy and other axonal neuropathies, etc. This can be in the form, the peripheral neuropathy here can be in the form of peripheral somatic neuropathy affecting the limbs, autonomic neuropathy, cranial neuropathy or uremic myopathy. All this come under the peripheral nervous system manifestations of CKD. We will go one by one. As mentioned, in chronic disease you have a neuropathy which is somatic neuropathy, and then you can also cranial neuropathy. In cranial neuropathy, olfactory, visual and auditory system are much more involved, and peripheral complications can also produce a myopathy. So, when it affects the peripheral nerve system, the limbs, it occurs in about 50 to 60% of the patients who have an end stage renal disease. It's usually progressive, can involve both the motor and the sensory axons. So, how does it manifest? It produces unpleasant, sometimes painful sensations that can lead to weakness of the legs as well as poor balance. And if there is weakness, then that is more a motor manifestation. The unpleasant sensations are more sensory manifestations, and balance can be because of motor as well as sensory. The mechanism here is because of the intracellular accumulation of calcium secondary to hyperkalemia, and this produces a reversal of potassium-calcium pump. There can be significant axonal damage and depolarization. Treatment is usually symptomatic and mechanistic. What I mean by this is, if there is anything in the region of the compression neuropathies like a carpal tunnel syndrome or a tarsal tunnel syndrome, then you try to avoid the compressive elements. Improving with dialysis helps in improvement of this. Transplantation can lead to reversal of neuropathic symptoms in certain selected patients. So, how do you treat these peripheral neuropathies? You treat it like a peripheral neuropathy, but only thing is you have to be careful about the use of drugs. These painful sensations or the painful paresthesias may respond to gabapentin, pregabalin, tricyclic antidepressants, in addition to carbamazepine, oxcarbazepine, etc. When you are using gabapentin in a patient with CKD, you have to be very cautious because this can produce a central nervous system toxicity also. Not much response to peritoneal dialysis, but improves with hemodialysis. Renal transplant helps in alleviating the peripheral neuropathy. The autonomic neuropathy can occur. It can present as impotence and gastrointestinal symptoms, which can be diarrhea or constipation, apart from bloating and fullness. When it comes to cranial neuropathy, you find that acoustic or the auditory nerve is the one which is commonly involved, and there is about increase in the peak 1 to 3 latencies on brainstem auditory evoked potentials in about 40% of the individuals, and you find that this improves after dialysis. The olfactory nerve also can be involved, and it affects the sense of smell. Myopathy is very commonly seen in uremia. We think it as just tiredness and go away, but when you examine, you find there can be proximal muscle weakness, can be muscle atrophy, and then when you do an EMG, there is features of myopathy. Can also have sarcopenia because of the loss of muscles. And the risk factor for myopathy is GFR, which is less than 25 ml per minute, and female sex and age 60 years and above. What is the cause for this? It's because of the increased cytosolic calcium in the myocytes. There's accumulation of intermediate molecular weight uremic toxins and mitochondrial dysfunction. Treatment will be inadequate replacement therapy, renal replacement therapy, improve the nutrition, can give L-carnitine supplementation, which also can improve the muscle cramps and fatigue, which can be present in uremic myopathy. The normal dose is 20 to 30 mg per kg in patients on dialysis. And if there is secondary hyperparathyroidism, you have to manage that, and then correct the anemia with recombinant erythropoietin. Be careful, this can also be a risk factor for stroke. Renal transplantation is helpful. Now, I will come to the central nervous system disorders related to uremia.